So good evening all. I am Vivek Shekhar, Group Product Manager, MQR Pharmaceuticals Limited. Welcome you all in today's very interesting session of HIV updates. So this topic for today's session is non-infectious issues with HIV and heart. So we have with us Dr. Ankita Baidya. So Dr. Ankita Baidya is Senior Consultant Infectious Diseases Physician at Manipal Hospital, New Delhi, and she is also faculty in charge and antimicrobial stewardship program at Manipal Hospital, New Delhi. She has been also nodal officer for COVID care committee and core member of Hospital Infectious Control Committee and editorial board member of National Journal of SIDS. So she has many honors and membership. She had chaired the academic meeting organized by IMA Dwarka. Dr. Ankita has infectious disease observership at Detroit Medical Centers, Wayne State, USA, and she has sponsored invitation to attend ICAAC 2014 meeting in Washington, USA. Her area of interest are HIV, hepatitis, tuberculosis, ICU infections, antimicrobial stewardship. So with this, I would like to hand over the session to Dr. Ankita. So she will be moderating the session.
Yeah. So if you can share the slide again.
Yes.
Dr. Pruthu's slide. Yeah. So good evening, everyone. So the speaker of the day is Dr. Pruthu Dhekane. He is a consultant infectious diseases and infection control at Fortis Hospital, Bengaluru. He has done his FNB infectious diseases from Apollo Hospitals, Chennai. Also did diploma in tropical medicine and hygiene from Liverpool, UK. He was a former lecturer, Department of Medicine, Dinanath Mangeshkar Hospital, former junior consultant physician at Symbiosis Center of Healthcare, Pune. He has presented challenging cases in infectious diseases at ID Week 2019 in Washington, DC, and his field of interest in treating community-acquired and hospital-acquired infections, infective endocarditis, osteomyelitis, meningitis, surgical site infections, and also tropical illnesses like HIV, TB, and MDR tuberculosis. Over to you, Dr. Pruthu, to take it forward, because today's topic is very interesting, non-infectious issues with HIV and heart. So we all know that when we talk about HIV as an infection, we think we are more concerned about only infectious diseases related to HIV. So it is an interesting topic that Dr. Pruthu and MQR Pharmaceutical has come up with, that talking about non-infectious conditions when we talk about HIV and also related to antiretroviral treatment. So over to you, Dr. Pruthu, to enlighten us, everybody, the participants related to this interesting topic.
Hello, very good evening to everyone. First of all, many thanks to MQR and team for inviting me to give this talk today. And thank you, Dr. Ankita, for those kind words of introduction. Let me just share my screen so that we can start with the presentation. Are my slides visible?
Yes.
Yeah, okay. So a very good evening to all. Today here we are gathered to discuss a topic which is rather probably not much discussed in HIV, because most of the times when we are talking about HIV, we are talking about HIV and HIV related opportunistic infections and newer drugs to treat HIV, and how are they better than the older ones. But I thought that let us see here and discuss here a topic which all of us, most of the treating ID physicians and physicians who treat HIV patients see more on a day-to-day practice, that is non-infectious complications of HIV. Because most of the patients nowadays, with the advancement in the antiretroviral therapy care, are coming more with non-infectious diseases rather than opportunistic infections. So First of all, thank you to all my teachers, because of whom I am here and able to give you and speak whatever little I can. So the UN AIDS just declared that non-communicable diseases is one of the most important challenges in the upcoming decade, and non-communicable diseases in HIV is an increasing concern in the global population. This was in response to the number of illnesses which are non-communicable in HIV, which are causing more morbidity and mortality. There was a saying, or there is still a saying, that HIV per se does not kill a patient, but the opportunistic infections related to HIV do kill a patient. But with the way how we are going, we may have to modify this saying in the upcoming years. How? Let us see in the subsequent slides. So as you can see on your screen, the leading causes of death in 2016 and expected leading causes of death in 2040 have been highlighted here. HIV stands among the at 8th position in the number of as the etiology for cause of death in 2016, and by 2040, with the advancement in HIV treatment as well as the good outreach programs in HIV, this HIV infection most likely will fall down to number 12. Is what the prediction is. Though ischemic heart disease and stroke, which are number 1 right now in the current decade, still would most likely be the most likely causes for death in 2040. Other infections like lower respiratory tract infections, diarrheal diseases, and AIDS-related illnesses also form a chunk of important causes of mortality and morbidity in this decade. But they are also expected to come down slowly in the upcoming 10 to 20 years. As you can see, the expected causes of death in 2040 are respectively COPD, chronic kidney disease, Alzheimer's, diabetes, lung cancer. All these are featuring in the top 10 causes of death. And many of these illnesses are something which are seen more commonly in people infected with HIV. And HIV illness, along with the antiretroviral therapy which we give these patients, to some extent definitely contributes in developing these diseases. So the Lancet came out with the article in 2013 saying that slowly now we are seeing the end of AIDS-related complex, and HIV is said to be treated more as a chronic disease rather than an AIDS-defining condition. So it even goes ahead and makes a prediction as regards how would we be treating HIV as a chronic disease in the future. As regards the epidemiology, it expects that most of the HIV infections which will be coming up will be less than what we are seeing at the present time. Almost there will be an elimination of HIV infections in children. This would be most likely because of a good MTCT program implementation, as well as the U equal to U principle, in which in serodiscordant couples, if the viral load is suppressed well, there is the offspring is less likely to get an HIV infection. Also, we will likely be seeing people who are living longer with AIDS, but are not cured of AIDS. As of right now, we have maybe only doubted. As far as right now, we have only 3 to 4 patients or people in the world who have supposedly been cleared of HIV or cured of HIV. Also, the AIDS-related illnesses and AIDS-related complex diseases would be less in the future. The immune profile, or they say immunological profile of the patients, would be initiated through earlier initiation of ART and the anti-inflammatory interventions and functional cures in some of these patients. Disease burden would be more of morbidity seen as an effect of aging population, when it will be similar to that of HIV uninfected people. Also, we are expecting no increase in risk of tuberculosis, perhaps in the upcoming future, as a risk factor for HIV. And in the overall, the location or the placement of HIV medicine would be integrated with community-based clinics, and HIV would be treated as on a community-based clinic rather than being treated as specialty HIV services. So what constitutes a HIV-related disease? AIDS-defining opportunistic infections, these are all something which we all are familiar with. It more commonly often occurs in patients who have CD4 counts less than 200. There are non-AIDS defining conditions, but AIDS HIV-related conditions, which are more commonly seen these days. These occur more in people who are having CD4 counts more than 200, as well as the people, because the incidence of OIs in these people are less, and these are the diseases which we have to deal more so often on our OPD practices. But yeah, lower CD4 counts increase both its defining conditions as well as the HIV-related illnesses. So getting the CD4 count of patients up as quickly as possible with starting ART should be of prime importance and prime concern for treating physicians. And once we do that, we'll be able to reduce the burden of both these illnesses in our patients. The renowned scientist, Dr. Mike Sark, said that the newly identified HIV patients would primarily be treated by HIV specialists only until their HIV-related issues are controlled. And once they are controlled, they would be most likely on a stable antiretroviral therapy, which they would be continuing to take, and their primary care would be transferred to their primary care providers. This may take 3 to 4 years, or maybe, let's be more optimistic and realistic, maybe another 5 to 10 years, but it may be the future of HIV medicine. So how does HIV cause these non-infectious or non-AIDS defining conditions? So HIV itself is a state of chronic inflammation. There is increased inflammation in people suffering from HIV with increased inflammatory markers like interleukin-6, interleukin-1, 2, and also TNF-alpha. Reduction in the anti-inflammatory cytokines like interleukin-10. And this chronic state of inflammation is something which leads to many of the HIV-related morbidity conditions. Also, there is monocyte macrophage system dysregulation, which results into transformation of macrophages into foam cells, and which are suboptimally functioning cells, and which lead to formation of more cells with increased immune dysregulation and lesser clearance of different types of infections which do come in the body. Also, there is endoplasmic reticulum stress, which happens mostly because of calcium imbalance, and this increased ER stress ultimately leads to apoptosis, and apoptosis is one of the major causes for development of plaque or atherosclerosis. So HIV positive patients have to face effects of this high pro-inflammatory state, increased levels of interleukin-6 and other markers. Alongside that, they have to also face the effects or the side effects of antiretroviral therapy. And along with that, as we see that the population is aging more because of good HIV control, the traditional risk factors of aging like obesity, increased obesity, increased poor glycemic control are some things which are frailty, which are conditions which people with HIV infection have to deal with as well. So because of all of this, still, as per the current statistics, we have the people living with HIV having a 9-year shorter lifespan expectancy than HIV negative people. But with upcoming treatment and upcoming diagnostic methods, as well as proper screening and treatment of patients early, this gap would probably shorten even further in the upcoming years. So these are the main non-infectious problems which all of us know, which we see commonly in our HIV patients. Diabetes, metabolic syndrome, cardiovascular disease, liver disease, osteonecrosis and osteoporosis, renal failure, neurocognitive disorders, and malignancies, which are related to non-infectious components of HIV infection. So all these conditions put a patient with HIV to a higher risk of succumbing, not only succumbing, but to suffering as well as succumbing to any of these conditions. And that led to a finding that a 40-year-old HIV infected patient had a similar risk to 55-year-old HIV uninfected patient for developing diseases which would develop at that age group. So coming to the first illness, HIV and cardiovascular disease, this is the most important factor related in morbidity and mortality because of HIV. People living with HIV are having a 50% higher risk of myocardial infarction than non-HIV people. People are also subjected to a 1.2 to 1.5 to 2-fold increase in the risk of acute MI and 1.9 fold risk of CDA when they were infected with HIV. Also, there was more diastolic dysfunction, and this was seen more so in patients who were getting ART in the form of PIs and NNRTIs. HIV also increases an individual's risk of developing stroke. And in HIV, higher viral load, low CD4 counts, multiple drug-drug interactions causing suboptimal drug levels, and concomitant HCV infection are factors which increase the cardiovascular and the cerebrovascular risk of these patients. More recent data showed that by the age of 60, the CVD risk would be 20% for men and 13.8% for women who are HIV infected, as compared to 12.8 and 9.4% for men and women respectively in the non-HIV infected population. So it's almost a 5 to 8% increase in the risk of HIV and coronary artery and cerebrovascular diseases as well. Lower the CD4 count, greater the risk, as we discussed earlier. And many of the MI, there are many risk calculators which are used for estimating the risk of development of MI or any other cardiovascular diseases. Many calculators, many scoring systems like the ASCBD scoring systems and MI risk calculators often underestimate the probability of developing MI in HIV positive hosts. So we cannot take a 1:1 correlation as regards these different scores and calculated scores in the HIV cohort. 50% of people who suffer from myocardial infarction in HIV suffer from type 2 myocardial infarction, which is an oxygen demand supply mismatch pathophysiology of myocardial infarction, rather than type 1, which is a plaque rupture or a thromboembolic episode occurring and causing myocardial infarction. So the overall focus in treating HIV patients and preventing development of myocardial infarction in them is to control the disease as well as prevent development of hypoxemia and conditions which can result in a oxygen demand supply mismatch, like development of acute renal failure or sepsis. Amongst the ART, as I discussed already, NNRTIs and PI-based regimens have got increased risk of development of MI, but abacavir, as all of us know, also has 1.94 to 4.3 times increased risk of developing myocardial infarction. This association of abacavir and cardiovascular risk is definitely strong and has been proven with multiple studies. So this needs to be taken into consideration while starting any patient on an abacavir-based regimens. PI-based regimens also increase the risk for MI by about 1.1%. In PIs, the later generation PIs like darunavir is associated with an increased risk of cardiovascular complications as compared to atazanavir and boosted atazanavir regimens. INSTI and NRTI-based regimens, apart from abacavir, have a lesser risk for MI. And amongst these, TDF, dolutegravir, and atazanavir are more lipid-friendly drugs, and which can be used and probably have a lesser chance of leading to development of myocardial infarction. As opposed to what would commonly be thought, that early ART would reduce development of cardiovascular or any other non-infectious conditions. Early ART does not reduce cardiovascular risk events. The START trial showed us that there was statistically no significant change in people in the cohort which was started antiretroviral therapy immediately versus late starting antiretroviral therapy. Amongst these people who are starting Antiretroviral therapy alone early were suboptimally found to have have a good effect on the CVD risk. But if they were given along with antiretroviral therapy, statin coverage, the outcomes were much more better. What this tells us is that when you're assessing any person, even at the first visit for diagnosing and at the time of starting HIV medications, do check the risk factors for development of cardiovascular events. Lipid profile is one of the one of the screening tools which we use to determine the cardiovascular risk. And if you have a patient with a deranged lipid profile, you should start these patients on statins as early as possible, so as to prevent the risks of development of cardiovascular events alongside early initiation of antiretroviral therapy. Statins have a variable interaction with protease inhibitors, so please do keep in mind if you're starting a patient who is already on a PI-based regimens on statins, there are interactions between PIs and statins. As we can see over here, atazanavir, darunavir, lopinavir, ritonavir, all these medications increase the concentration of rosuvastatin in the blood. So always use the lowest possible dose to control the lipid profiles of these patients. Meanwhile, other classes like integrase inhibitors are found to be affecting lipid profile less as compared to the PIs and can be used more safely. Coming from heart to the kidney, renal failure is more more commonly seen in people suffering from HIV infection. Prevalence of CKD in the HIV population ranges from about 4.7 to 9.7%. And most of the HIV-related renal failure is because of HIV-associated nephropathy, immune complex-mediated glomerulonephritis, antiretroviral drug toxicities, and glomerulonephritis because of HCV co-infections. Amongst the ARDs, TDF-boosted PIs are the most likely agents which predispose to renal failure, and high HIV RNA viral loads at the beginning also have a higher risk of predisposing the patient to renal failure. Alongside these risk factors, the traditional cardiovascular risk factors such as diabetes and hypertension also contribute with increasing age to the development of acute kidney injury, and even may proceed to development of chronic kidney disease. So any condition which precipitates or favors development of AKI in the background of an HIV infection is something which is likely to lead to catastrophic renal failure. So always attend to these patients as quickly as possible. If they're presenting with fever, try to find out the source of infection, prevent sepsis, and prevent dehydration to prevent development of acute severe AKI. What can you do in your regular practice to check whether patients are developing any AKI or CKD is you need to evaluate at least twice in a year the GFR by calculated estimated GFR with measurement of creatinine, and once a year checking for urine albumin or urine protein, urine albumin, urine creatinine ratio. So if these are under well control, your patients are relatively safe and are on a safe regimen which is covering and not harming the kidneys. What can HIV cause? What are the renal effects because of medications of HIV? So HIV-associated glomerulonephritis is focal segmental glomerulosclerosis, which is more commonly, which is the etiology or the etiopathogenesis of HAART. Atazanavir predisposes development of acute interstitial nephritis and also can cause development of hypersensitivity type of reactions. Indinavir, though not commonly used now, is a known agent to cause nephrolithiasis and crystalluria. Tenofovir acts on the proximal renal tubules, can lead to development of acute kidney injury because of that, and also development of Fanconi's syndrome is important in people who are on tenofovir-based regimens. These are concentration dependent, so the risk increases with increased serum levels of this drug, and if given concomitant with the PI-based regimens, the risk increases even further. The best way to deal with any tenofovir-related renal toxicity is to stop tenofovir and change to some other NRTI agent, most likely abacavir. Also important to mention here is that many of the agents which we use to treat opportunistic infections in HIV also are nephrotoxic for condition like, for example, conditions like cryptococcal meningitis, the usage of amphotericin B, the uses of acyclovir for herpes simplex infections, and usage of cidofovir foscarnet for CMV infections. All these agents are nephrotoxic. So the combined effect of these agents along with the antiretroviral therapy can lead to significant renal effects, and they should be monitored very carefully. So the incidence of HIV causing incident renal disease was studied in about 6,000 patients who are on antiretroviral therapy and who had initial GFR more than 15. It was seen that any people who are having a decrease in GFR by 50% or more, or which is equivalent to doubling of creatinine in 3 months, were considered and were evaluated for probable causes of worsening or development of renal disease. They found out that approximately there are 131 episodes, which amounted to 0.7 per 100% years of incidence of HIV-associated renal disease, and more were associated with people having higher viral load, people with diabetes mellitus, and people who were on antiretroviral therapy for more than 10 years. So a substantial burden of renal disease was found out in HIV-infected patients, and cumulative viral load along with associated renal disease suggested that early control of viral load and proper monitoring of the kidney functioning is something which is more important, which can prevent development of acute kidney injury or chronic kidney disease in these patients. Coming to our next complication, osteoporosis. So this is another important non-infective condition in HIV and people taking ART. 67% of people who are suffering from HIV were seen to have osteopenia, and about 15% having osteoporosis. More the osteopenia and osteoporosis, more was the adjusted risk for fractures, which was 2 to 3.7 times more higher. Fractures were 3 times more common in HIV patients than in non-infected HIV patients in the age matched subgroups, which was seen in a study. The risk of fracture was higher if the patient is older and has a lower CD4 count, which by predisposes to a higher viral load and a higher state of pro-inflammatory state. The bone mineral density lost in HIV after starting antiretroviral therapy is something which is a little bit not linear. It is a biphasic BMD loss curve, which we see. That means that initially when we start HIV therapy for patients, there will be a fast decline in the BMD levels for patients during the first 6 months after starting the therapy. This is more so because of the increased body immune response, which causes an increased inflammatory response, and leading to a decrease in bone mineral density upfront. And as the CD4 counts increase and start going below 200 or 300, and the viral load starts coming down, this rate of BMD loss slowly decreases further, but and thereafter it is still there but continues at a lower rate. So the first 6 months after starting ART in a HIV ART naive patients, there should be focus on the bone mineral density for that patient, especially in elderly people and postmenopausal females, because they are most likely to have osteoporosis by default. And for them, probable supplementary calcium or vitamin D should be started upfront with screening for both of these. So Coming to the drugs, tenofovir, as we all know, and atazanavir reduced bone mineral densities. Tenofovir increases the risk of fracture by about 12%. Patients who are switched from tenofovir to zidovudine experience a significant decrease in bone mineral density, and this along with change of regimen. If patients were supplemented with vitamin D and calcium supplementation, the risk was even further reduced. In patients who are having refractory osteoporosis, despite of giving supplements of vitamin D, calcium, and even giving biphosphonate therapy, bisphosphonate therapy, if the patients still are having refractory osteoporosis, then one should consider in changing the antiretroviral therapy from a tenofovir based therapy to something which is less toxic to the bones. How to screen these patients? Well, we can screen by doing a regular DEXA scan and seeing the FRAC score for these patients. As I said earlier, men more than 50 years old and postmenopausal females, along with people who are on long-term ART, especially with PI or tenofovir-based regimens, have a higher risk of developing osteoporosis. The pharmacological treatment of osteoporosis should be offered to these people if on the DEXA scan their T-score is showing a score less than or equal to minus 2.5, or if the patient has a history of fracture or spine of the hip, these people should be started on pharmacological therapy for osteoporosis. Obviously, other lifestyle changes like smoking cessation, increasing weight-bearing exercises, and consuming a diet rich in calcium and vitamin D are supplementary factors and which should be counseled well to the patient at every visit of the patient. Also, make sure that you are not missing out any secondary causes of reduction in the bone mineral density. Make sure that there is no hypoalbuminemia, no calcium deficiency, which is very commonly seen in the Indian subpopulation, in the Indian population, calcium and vitamin D deficiency. Also check for increased alkaline phosphatase levels in hyperthyroidism and total testosterone levels, which could be other secondary causes leading to worsening of bone mineral density and causing osteoporosis. 6.4 to 3 versus 3.7 was the risk of development of reduced bone mineral density in HIV positive versus HIV negative population in an age match control. As I said earlier, T-score and Z-score are scores which are used in the bone mineral density testing on DEXA scan, and it can be used for people above the age of 50 years where T-score is used, and below the age of 50 years, Z-score can be used. And people who are having lower scores, lower than 2.5, minus 2.5 in both of these conditions do require treatment. So this is the rough algorithm which you can follow for any for all your patients who are having a risk of osteoporosis. Always check the FRAC score, do a DEXA scan at least once in every 5 years for people who are who have not been earlier tested with a DEXA scan and are above the age of 50. And if the patient also follow doing it every 5 yearly if the patients have normal bone mineral density on a DEXA scan, so as to catch early any development of osteoporosis. In case osteoporosis or osteopenia is found in any of the patients, increase the calcium and vitamin D intake along with behavioral modifications. Consider bisphosphonate therapy, and if the patient is on antiretroviral therapy, which could be contributing to development of osteoporosis despite of taking treatment for the same, then you can consider switching the antiretroviral therapy to from tenofovir to an abacavir or raltegravir based regimen in case of INSTI based regimen instead of the PI based regimens. So for bone mineral density, low bone mineral density is very prevalent in HIV population and should be evaluated properly. Age, habits, ART medications, earlier onset of the disease, poor control of disease, and the baseline health and nutrition status are important characteristics for development of osteoporosis and osteopenia. How do you treat these patients? It's a busy slide, so I will not go much in detail of this. Treatment of osteoporosis, you can, along with calcium and vitamin D, you can give a patient bisphosphonates, calcium zoledronic acid 5 milligrams once yearly, or alendronate 70 milligrams once weekly. Supplement it with calcium supplementation of 1000 mg per day and vitamin D of 400 units per day. This is especially for people with a T-score less than 2.5, and do continue this treatment for at least 3 to 5 years, and do not stop it immediately, even if your DEXA scan shows improvement in the BMD. I've already said this, so supplementation of vitamin D and calcium are important. And do remember that efavirenz, if the patient is on efavirenz-based therapy, efavirenz has been shown to cause steady reduction in the vitamin D levels for patients. This is mostly postulated due to the increased enzyme inhibition of CYP enzymes, which are used in the 25-hydroxylation of vitamin D. So do keep a watch on vitamin D levels if your patient is on efavirenz-based regimens. Coming to malignancies, these are malignancies which are non-infectious related malignancies in HIV AIDS in HIV population. The rates of fatal non-AIDS defining condition of cancers were around 10%, 10 times lower in people who had got better CD4 counts, at least more than 500, than with CD4 counts less than 50. In the START trial also, it was shown that 74% lower rates of infection related to cancers were seen in people who received treatment earlier. And about 10% of death in people in HIV are related to non-infectious malignancies in HIV infection. So all of us know the AIDS-associated malignancies like Kaposi sarcoma, lymphoma, CS cervix, hepatocellular carcinoma, etc. But non-infectious complications are something which we would like to stress upon here, which includes anorectal cancer, colorectal cancer, lung cancer, breast cancer. These conditions are more commonly seen and are exacerbated if a patient is suffering from HIV and also taking treatment with antiretroviral agents. Multiple studies have shown us this, and as we can see, the most likely malignancies which are seen in patients with HIV are of anorectal region, of lung, CA lung, prostatic cancer, colorectal cancer, and to some extent in oropharyngeal and cancers as well. So breast cancer, not to forget about that, is also one of the non-infectious malignancies which is commonly seen. From malignancies coming to weight gain, this topic has been seen and discussed multiple times in multiple talks earlier, so I'm not going to waste much time over here. All of us know that weight gain is an important factor in people receiving antiretroviral therapy, and now with more and more usage of a dolutegravir-based or NST-based regimens, we are seeing people with more weight gain as compared to people with using the efavirenz-based regimens. So as we can see, weight gain is more pronounced in women as compared to men, and weight gain is more upfront in the initial starting phase of antiretroviral therapy. As you can see here, the graph, the slope of the curve is more rapid in the first 6 months of treatment, and later slightly comes down as you continue with the treatment, but nonetheless continues with an increase with an increasing trajectory. So as we can see over here, patients receiving INSTI-based regimens were having at least a mean weight change of 2 to 4 kg more as compared to those receiving an efavirenz-based regimen. Also, TAF TAF is more likely to cause weight gain as compared to DTG, and comparing TAF versus TDF in patients receiving antiretroviral therapy, TAF was shown to have caused more weight gain as compared to patients on TDF-based regimens. How does the HIV status of the patient correlate with the weight gain? So the advanced study also showed us that more people who are having more viral load, more than 500,000 copies, or having a CD4 count of less than 200 were likely to have more weight gain, especially in the first few months after starting antiretroviral therapy, as compared to patients who are having a lesser viral load and having a more CD4 counts. So upfront weight gain is quite significantly seen in most of the populations. The reason for this weight gain mostly is compensatory weight gain, which is seen as regards the weight loss which occurs because of HIV, chronic HIV infection. And so not necessarily is this weight gain every time bad in people, but as we saw in the earlier graphs, this is the initial weight gain is followed by a continuous upstream increase in the weight of these people when they are continued with these therapies. So weight gain is something which should be monitored at every follow-up for all the patients receiving antiretroviral therapies. Amongst the antiretroviral therapies, which are agents which are more likely to cause weight gain, are INSTIs. As we can see over here, the weight change 3 kgs from baseline, 3 kg increase in weight gain was seen if you are using INSTIs as compared to PIs or NNRTIs, which showed 1 to 1.5 kg, and an absolute weight increase of about 3 to 4 kilograms extra was also seen over a period of 96 weeks in people who are receiving INSTIs rather than PI-based regimens or efavirenz-based regimens. Among the INSTIs, bictegravir, dolutegravir, and elbitgravir did not show significant difference in weight gain, though there is a small gap here in the graphs that we see in between elbitgravir and bictegravir DTG, with both of these being more commonly associated with weight gain as compared to elbitgravir. But overall, all the three INSTIs are known to cause weight gain, and bictegravir, dolutegravir being the second generation INSTIs are known to cause more significant weight gain than elbitgravir complexes. More weight gain with TAF other than TDF, as we already discussed. Again, it's shown in these graphs. Also, more weight gain was seen in patients receiving rilpivirine as compared to efavirenz in a patient who was receiving an NNRTI-based regimen. So rilpivirine, even if probably better in controlling the viral loads, was leading to an increased weight gain. But as I already mentioned, most of these weight gains, if you see the graphs, most of these graphs are having an initial high slope, increased slope, which shows a rapid increase in weight, and later on they slowly start to go into an ascending plateau kind of a phase in which the weight gain is there, but at a slower rate. So this is the stage in which most of the people or the patients should be controlled very well with other factors like lifestyle modifications and other medications if required to control the weight gain for these people. Metabolic syndrome. So as all of us know, metabolic syndrome is increasingly seeing in even non-HIV infected people with our current lifestyle, and this leads to development of dyslipidemia, increased risk of non-alcoholic fatty liver diseases, and increasing development of visceral adipose tissue, increased visceral adipose tissue concentrations, and also diabetes mellitus. So a chronic inflammatory state because of the HIV infection, along with antiretroviral therapy itself, all leads to development of metabolic syndrome. And even treating patients with combination ART does lead to change in the gut microbiota and does cause development of some changes of metabolic syndrome. What does this do to patients who are treated with antiretroviral therapy, especially people who are getting PI-based regimens, see a more increase in their lipid profiles. There is more dyslipidemia with hypertriglyceridemia, increase in VLDL as well as LDL cholesterol, and decrease in the VLDL to LDL and VLDL to IDL transfer or conversion rates. Also, there is decrease in the hepatic lipase activity, which reduces the low density lipoproteins and decrease the lipoprotein lipase activity as well. So all the factors related with HIV treatment, not only with PI-based regimens, but with other regimens also to some extent do cause and contribute to dyslipidemia and development of metabolic syndrome. So in PIs, ritonavir is the main responsible agent for causing PI dyslipidemia, and it does by altering the insulin resistance, by altering the expression of apolipoprotein C3 gene, and also with a multifactorial action on hepatocytes, adipocytes, and the endothelial enzyme abnormalities. Quickly moving on towards HIV and neurocognitive disorders. HAART, as all of us know, is a rarely seen condition of HIV, and which is characterized by the slow deterioration of memory, cognition, and behavioral, along with motor functions in HIV infected individuals. It is usually seen in the later stages of HIV infection when the immunodeficiency is quite severe. It is a combination of metabolic encephalopathy, which is fueled with immune activation of macrophages and microglia, resulting into some sort of an iris kind of a response. And this can be difficult to pick up if not screened for at every patient visit when the patient is seeing you. Normally, the patient or their relatives might give a subtle hint as regards behavioral changes. So do not neglect these changes. Always try to screen for HAART. This can be done by asking 3 simple questions as regards memory, as regards cognition, with respect to any differences in the patient's daily working habits, and any attention deficits. If these attention deficits are leading to difficulty in occupation or lower performance at school. So always screen for HAART with the HAART questionnaire, and rule out other conditions which can mimic HAART-like condition, HAART-like syndrome, like in other psychiatric conditions, use of other psychotropic drugs, and obviously rule out any other opportunistic infection which might be causing HIV encephalopathy. This is a different topic. I will not stress too much upon this, but just a glance over this, that isolated CNS virological failure can be seen in patients, and that can be sometimes seen in the form of OI, or it can also be seen in the form of HAART. And in this separate testing of CSF HIV viral load needs to be done. There are 2 schools of thought as regards treating patients with isolated CNS virological failure. One school says that modification of antiretroviral therapy is not recommended, but for these conditions, more so focus should be laid upon any drug-drug interaction leading to suboptimal levels and presence of any other opportunistic infections precipitating these conditions. These should be looked into. But earlier, older theories do say some drugs are more penetrative into the blood-brain barrier and have a higher CPE score, and those should be substituted for the antiretroviral therapy which the patient is using. But that is there is still debate as regards whether using CPE score is correct or not in patients with isolated CNS virological failure. But most of the evidence goes towards continuing more effective therapy rather than changing therapy to a CPE-based score-based regimen. And finally, coming to another important condition, that is frailty and high pill burden. Frailty is something which is defined as clinically recognizable state of increased vulnerability, which is associated due to aging, and it leads to a decline in reserve and functional ability of a person across multiple physiological systems. In short and simple, it's the changes which we see with aging, which happens in every person, even if they're not suffering with HIV/AIDS. People with HIV have more frailty and have more disability because of frailty which is caused to them. This frailty is because of the HIV infection, as well as many of the antiretroviral therapies which they are taking, which leads to conditions like decreased bone mineral densities, reduced dyslipidemias, and metabolic syndrome, obesities, etc. This is a significant factor because frailty negatively affects people's lifestyle and health status, and it is an important factor which needs to be considered in the upcoming future, because we'll be having more people who are living longer with HIV and who are on antiretroviral drugs, and a physical as well as a mental well-being of these patients in their later decades of life is something which will have to be prioritized when we are treating and following up these patients. So frailty is something which everyone should know, and that should be understood as a separate entity in HIV positive patients. With increasing frailty, there is always polypharmacy and more risk of fall in people who are suffering in HIV, and this usually happen 15-20 years earlier than in the general population. The pill burden of patients taking antiretroviral therapy is definitely high, because as age increases along with other illnesses, the ART adds on the pill burden. More the pill burden, more is the chance of non-compliance with ART, and if there is non-compliance, it may lead to failure of HIV treatment, and then scaling up of treatment and more second line and third line agents which need to be used. Also, multiple drugs means more and more drug interactions, and that can lead to various PK/PD effects, which can lead to increase or decrease in serum concentration of multiple antiretroviral drugs. So these all are important factors which should be considered in patients who come to you as a follow-up for HIV and who do not have any obvious opportunistic infections. Exercise is believed to be the best strategy to prevent frailty. So apart from taking the medicines and following all the lifestyle changes, exercise should be encouraged very much predominantly in people suffering from HIV. So what do patients in HIV positive patients die of in the ART era at the present moment? So most of the people die of metabolic syndrome, cardiovascular events, and non-HIV AIDS related malignancies. So this is in short what should be screened at every patient visit who is visiting you on HIV follow-up. Weight monitoring should be done at every visit. Patients' urine serum creatinine and urine dipstick tests for testing urine albumin, urine protein, urine creatinine ratio, especially if the patient is on tenofovir. This should be checked at least twice a year. Hand screen is enough if done at least once in a year. Annual lipid profile, annual fasting blood glucose and blood pressure monitoring, checking for other medications which the patients are taking, checking for any potential drug interactions in the other medications which these people are taking, especially interactions with anti-diabetic agents, statins should be checked for, and dosage of drugs should be monitored accordingly. Smoking cessation, as I said, lifestyle changes of smoking cessation, exercise, and better food consumption as regards consumption of food with lesser glycemic index should be encouraged. For non-HIV related cancers, mammography for women aged more than 50 and self-breast examination for women aged less than 40 is something which is now regularly recommended. Also, screening for any neoplasias, especially CA lung, any GI tract malignancies or prostatic malignancies should be part of the workup for patients who are following up on antiretroviral therapy. DEXA scan and vitamin D level, as I said earlier, should be done at least once every 5 years to check for any development of osteoporosis or osteopenia. And the most important factor is that looking at all of these, it makes us think that if HIV can cause and can affect so many things which a normal person without HIV can also does have, why should we not include HIV as a part of this, as a part of a regular annual health checkup for people who come to our OPDs? There are so many people who come and turn up incidentally positive on an annual health checkup, or if they're traveling, especially students who turn up with a positive HIV on such travel screening. So HIV should be considered as a screening test as a part of annual health checkup, which will help us detect people who are suffering from HIV much earlier, and also treat them much earlier in order to prevent infectious as well as non-infectious diseases with HIV. I think this is my last slide, and thank you for your patient listening.
Thank you, Dr. Pruthu. So it was very well elaborated. All the factors related to non-infectious complication that we see in our practice related to HIV and heart therapy. So very nicely covered. So we have some questions in our Q&A box. So I'll just quickly take it. So Mr. Vikram Das has asked, you have already mentioned in your presentation, but if you want to just quickly mention it again, that when should we order tests to assess BMD and DEXA scan after starting ART? And is it symptom based or should be done routinely for all patients?
So if you're starting a antiretroviral therapy for any patient who is above the age of 50, especially males, and postmenopausal females, BMD DEXA scan can be done upfront at the time of starting antiretroviral therapy as well. And if the patient is having deficiency, treatment should also be started simultaneously along with the ART. If your patient is not having a normal DEXA scan upfront, then it should be repeated at least once in every 5 years. And yeah, that should be continued further. In people who are less than age 50 and who are premenopausal females, for them once in every 5 years should be enough, and it can be done not at the first time. You can perhaps avoid doing it at first time. When the patient presents to you with HIV, you can maybe screen it at a later date, maybe after on the second or third follow-up.
Yeah, and very important, especially for the postmenopausal women, rightly said. And another question is by Chavi Gupta, the change in ART with AKI. So what exactly you practice related to ART therapy when you are seeing that somebody is going into acute kidney injury?
Right. So the most important factor is in trying to decipher what is the cause of the AKI. Is the AKI being caused because of the ART, or are there other contributory factors? As I said, as the population ages, other factors like metabolic syndrome do come into picture, and which can contribute to the AKI. So checking urine protein, urine creatinine ratios is important in this. And if we cannot find any other factors and probably ART is the cause, then using regimens which are relatively nephrosafe is something which can be done, like substituting your NRTIs in with from a tenofovir based regimen, you can shift to a abacavir based regimen. Also, TAF is slightly less nephrotoxic as compared to TDF, so patients can be even shifted to TAF, but not a practice which I would recommend if you are having a definite proven AKI because of ART. In that situation, drugs to go would be more of an abacavir based regimen.
Yeah, rightly said. So basically, we need to evaluate what is the cause of AKI. And sometimes it is not related to the drug itself, but if at all, if the creatinine is deranged, we can, and there is underlying metabolic syndrome, a patient had an underlying CKD also, then we can plan to change the drug from tenofovir to maybe abacavir after ruling out HLA-B5701 sensitivity test. So rightly covered. So another question by Dr. Vimal Mathur is there. It's he has asked about calcium and vitamin D supplement, what time of the day it should be given. So I think for calcium and vitamin D3 supplement, usually we avoid giving with ART, and it can be taken separately in the alternate time, because right now these days we have single pill in this ART regimen that we are giving to our patient, and we can just space them, calcium and vitamin D3. And it is important that we are also screening the levels of vitamin D3 before actually supplementing them on a higher doses. So you have already mentioned this in your talk, very effectively covered. Another question, if you see, there is a how to differentiate atazanavir associated nephropathy versus HAART.
So the best way to answer that is, take the help of your nephrologist, because this is more so a histopathological based diagnosis rather than a clinical diagnosis. First, as I told you, urine albumin can help differentiate whether we are having a glomerular problem or a tubular problem. But if you're suspecting,
biopsy.
yes,
Biopsy will be required.
Biopsy will be the definitive answer for that.
And another question is there by Mr. Dinesh, that I have a patient who has HIV and rheumatoid arthritis undergoing tab methotrexate. Does it will impact on immune system? If so, can we continue it or not? So I believe that it also depends upon what is currently the HIV status, what is the CD4 count, the viral load of the patient, and how acute presentation of rheumatoid arthritis is there as such. HCQS and SARS sulfasalazine is actually the most preferred drug when we are treating rheumatoid arthritis with HIV. Methotrexate can also be given, but we should always weigh the benefit versus the risk when we are using such kind of immunomodulators along with giving with HIV co-infection. You can add on this if you want, Dr.
No, I think we have covered it mostly. You cannot. We have to treat the rheumatoid arthritis. Also, we have to treat the HIV. So, regimen of HIV of antiretroviral therapy has to be continued, and you have to keep a close watch on the CD4 counts of these patients, because they will be on methotrexate for their rheumatoid arthritis. Try to keep the CD4 counts prevent the CD4 counts from falling below 300 or 350. That can be considered as a good target, and if they're above that, they are good enough, and there should not be any reduction of dose of methotrexate. That's what I feel.
Yeah. And first line, they can always go for HCQS and sulfasalazine, because that is a preferred drug when we are treating HIV. So another question is, what is the mechanism? This is the last question I see in the Q&A. What is the mechanism for checking urine albumin creatinine ratio in PL-HIV non-TDF based regimen? So the HIV patient is on non-TDF based regimen. What is the mechanism? I think we just go in for 24-hour urine albumin protein creatinine ratio. That's it. It's a 24-hour collection, and you asked the patient to do that and submit in the lab. This is how we go about it. So there are another reasons also related to TDF based, non-TDF based nephropathy. In HIV also, you have rightly mentioned about HAART is there, and there are another comorbidity like development of diabetes while on treatment. So if you want to add on this question.
Yeah, so mechanism is, as you rightly said, how to do the test. It is quite simple. There are spot urine test is also one option, and 24-hour urine collection is the better option to go for a more comprehensive and accurate result for it. And I don't think anything else can be answered for mechanism of the curve.
So another question by Dr. Parvati. So we are taking this last question because we are actually running up time now. So Dr. Parvati has asked, do you think DTG is nephrotoxic? And we have few patients on ZL DTG who has raised creatinine values. So what comments do you have on this?
So per se, dolutegravir has not been shown to be a agent which causes AKI in HIV individuals. And if you're having people on zidovudine and lamivudine based therapies, more than DTG, I would suspect the lamivudine component to be contributing to the raised creatinine values. If you have already ruled out other causes of development of AKI in these patients, I'm assuming that these patients are probably good, having a good virological suppression. So if the regimen is successful, then probably we could be dealing here with some other cause of nephrotoxicity, or it could be, if I had to pick a drug among these three, maybe it would be more towards the NRTIs like lamivudine rather than dolutegravir.
Yes, yes, Dr. Pruthu. So just to summarize, Mr. Vivek, we need to do anything else also? Any other questions do we need to take?
I think there is only one.
We are
question.
Already running out of time. Yeah.
Yeah, there was one question: how to screen for GI, lung, prostate
malignancy. Right.
Yeah, so screening for these is a little bit difficult because you don't have a single test, a blood test, and you cannot ask patients to go for endoscopies and colonoscopies just like that. But a better way to do for it is you have some simple markers. You can do a simple imaging test for these patients and try to get more of risk factors. If the patient along with HIV is having other risk factors like smoking, excessive alcohol consumption, or a family history, then be a little bit more proactive as regards screening for these malignancies. X-ray for a lung should be good enough, I think so, upfront as a basic investigation. If you're suspecting more, definitely more CT scan would be required. And for GI malignancies, you can always consider using endoscopies or the certain GI biomarkers. I'm not able to recollect the names of these, but these you can use as markers for screening for these malignancies.
Yeah, just completing that AFP-C and CA19-9 can be used. Yeah, right. So very nicely covered, Dr. Pruthu. It was very, very wonderful. This topic is actually extensive, but you have tried to cover all aspects in this. I think we have answered all the questions that was there in the Q&A. Mr. Vivek, you can.
Yes, all the questions are also answered. So I think we should close the session with the thank you remarks. I would like to thank you, Dr. Pruthu, from the end of MQR Pharmaceuticals, for enlightening us on this is non-covered topic, like non-infectious issues with HIV and heart. So you have covered all the things like myocardial infarction, renal effects, like osteoporosis, then malignancies, weight gain, metabolic syndromes, dyslipidemia, and everything you are covered. So thank you very much for accepting our invite as well as giving your thoughts. I would like to thank Dr. Ankita also for accepting our invitation and moderating the session. And not last but least, thank you for all delegates and participants for attending today's session. So thank you very much all. So happy weekend.
Thank you very much.
Thank you.